Good evening. Good evening to one and all. It's been a privilege to organize this meeting today. We start yet another teaching session of the Indian Society of Hip and Knee Surgeons. Today's teaching session is going to be started off by Dr. Rajkumar, Senior Consultant Orthopaedic Surgeon from Ganga Hospital, Coimbatore. He's going to be talking on choosing the right kind of femoral stem in primary revision THR and what are all the nuances that one needs to consider in deciding on what type of stem to be used in a particular case. So I hand it over to Dr. Rajkumar. Dr. Rajkumar, please go ahead.
Yeah, Leo, before starting, somebody else is controlling the screen. My PPT is not moving. I'm not able to move forward. Somebody else is controlling, I think.
Are you able to? Yeah, are you able to move it now? I see your mouse moving.
No, I'm not moving. Okay, one second. I'll stop sharing and then again I'll reconnect.
Yeah, restart again. Yeah.
Yeah, now going. Yeah. Got it. Okay. Okay, now got it. Okay. Good evening to all. Leo, can you see the screen and audio?
Yeah. Yes, we can see it. Yes, we can see it.
Okay. Yeah. Good evening to all. And I would like to thank the entire Ishks team for giving me this opportunity and inviting me for this evening webinar session. A very good, interesting topic and quite a practical topic to take some good points. So I've tried to cover some basic points out and some practical tips and take-home messages out of this title given to me. So choosing femoral stem in primary and revision total hip replacement, quite a big topic. Let us see how much I can do justice to the title. So if you see the hip replacement, these are the four options we have at present. That is the uncemented, cemented, hybrid and reverse hybrid. So when coming to uncemented hip replacement, the basic crux about the outcome is the micro motion. The more we minimize the micro motion between the implant and the bone, the better the longevity. So we need to have very less, that is less than 20 micrometer of micro motion should be there. Predominantly it helps in bone formation. So considering this factor, for the good outcome, we need to consider the implant design, appropriate surface treatment, and the primary mechanical stability and patient's osteogenesis. All put together gives us the good result. So the implant that handles all the above factors should be the best option and we should select. So coming to uncemented system, in the market we have so many options available. So we should try to select, as a young surgeon, we should try to select one or two options and try to do that regularly. Try to select the implant which suits the patient's anatomy. So we have, if you look at the basic anatomy, the stem has got a neck, then the body, and it creates an angle. That is the angle which is like either it is 125 or a 135 degree neck shaft angle. Then the design and the material, geometry, coating and the length. All these three things we have to consider. So based on this information, we need to classify what kind of stem it is. Then it keeps us in our mind so that when we see the X-ray, we can select the appropriate stem. So this article from JBJS categorizes and updates the classification system, and based on that let us go through the classification. So type 1 stems are called as the short and ultra short stems. These stems come into the market, they are widely used particularly in European countries, and then with some bad results it is taken away. So like that it comes and goes. We have to be little careful before using this. So we have to know the main advantage is bone preservation, and we try to keep the future revision in our mind. So for in that regards, this stem came into practice, but not much is routinely used. Another one is the in type 1 itself, type 1D is the shortened tapered stem called the actis or insignia in striker. So these stems are also called as type 1 stems. Now slowly this is becoming more and more popular, particularly with the direct anterior approach. These stems are becoming popular because the geometry is in such a way that laterally it is shaped and it is almost like a hexagonal shape with a lot of importance given to the length and the shape with some collar in it. So it is mainly for anterior direct anterior approach, and the coating is quite dual coating. It has got a titanium with a HA coated, and also proximally some highly porous coating has been done. It's called as a duofix. Then the type 2 stem. The type 2 stem is the most commonly used in nowadays in our practice. In fact, I will suggest one of the go-to stem in my practice also. It is a single wedged type. It is mainly wedged in one plane, that is mediolateral. It is flat and thin in the anteroposterior plane. So mediolaterally it will be broad and flat in the anteroposterior. Preparation requires broaching and no need of distal reaming, and the stem is also reasonably short, the type 2 stem. And the most common stem what we use is the Oculate 2 or an ML taper from Zimmer, Oculate 2 from Stryker. These are the most commonly used single wedge type 2 stems. So type 3 stems is a double wedged stem, and where the proximal cortical contact is in two planes with double wedged at a metaphyseal filling stems. The next one is the type 3 stems. Type 3 stems needs both distal reaming and the proximal broaching, which is very commonly used are synergy stems and summit stems. Synergy from Smith & Nephew and summit from Depew. If you look at the synergy stem, the literature wise, the longevity is very good. The success rate is almost 98 to 99%. A very good, excellent stem. But the problem is it's quite longer. So it is almost, the fixation is in the metaphyseal region. So in a primary situation for Indian patient, this is quite a long stem. So this is type 3. So type 4 is again metaphyseal filling stems like a Mallory Hedson or a Zoe Muller stem from, but it is not currently used very routinely. Type 5 is the Wagner cone prosthesis type of stem. That is like diaphyseal engaging, but it is a short stem, particularly in a dysplasia kind of proximal anatomy distorted kind of pathologies. This is very good. Type 5, particularly type 5 is a cone Wagner. It's a monoblock cone Wagner. Type 5B is again a cylindrical stem like a solution stem, but it is a cobalchrome stem. But it is better nowadays. We try to avoid these stems because the stress shielding is more, thigh pains are more, breakage is more. So cylindrically fully coated these kind of type B stems better to avoid. So next is the type 6, that is the modular neck. So this again with the bad reports, earlier reports, these stems nowadays are not much in use because of the too much of modularity and the metal wear and the debris and failure. So better to avoid these kind of stems. Type 6B, very commonly used modular system like the SROM modular system. Again very helpful in altered anatomy. So these are the basic type 1, type 2, type 3, type 4, type 5, type 6. So you need to know what kind of stem we are dealing with. So this is type 10, again an anatomic curved fit and fill stem. Again challenging, and the technique wise it is very we have to be very careful in the preparation. Better in our part of the world, that is in our country, we don't normally routinely use this. So based on this knowledge, let me take you through some examples. This DORS classification is very helpful to give you an idea what exactly we are dealing with, what kind of bone. So you all know, might be knowing this classification. That is the DOR type A is called as a champagne flute, TOR type B, and then TOR type C is a stovepipe. So based on this, let us see some examples. Also, we have to measure the calcar to canal ratio to determine the bone types. So if you see, you have to measure it both in the AP and lateral view. So you look at this example, 62 years male, it is a DOR type A canal. So narrow medullary canal and arthritis in the right hip. So here I have used a type 2 single wedge stem, that is an accolade type of stem, uncemented cup and a 28 head. So with this, with the help of this, we are not trying to convert this DOR type A too much into a type. If you want to use a corail type of stem, then it is a challenge. We have to convert that type A to type B, and still the avoiding a aseptic loosening when we try to convert that, it's a big challenge. So this is an ideal stem for this kind of situation. So whatever might be, whether we use a type 2 type of single wedge stem or a type corail type of stem, in a DOR type A, the chance of periprosthetic fracture is very, very high. So you have to be very careful. For that, the right size and the right amount of preparation and the technique wise, we have to be careful. So this is again one more example, type 2 single wedge stem, 44-year-old patient, is not very old, and you can see that is the canal is very, very narrow, short. So again I have used a accolade type of stem. 59-year-old male, again here I have used a DOR type A, but still I have used a type 3 double wedged metaphyseal filling synergy stem, uncemented hemispherical cup. So again, one more example, 69-year-old male, synergy type of stem. So if you look at the literature, 99.5% of survival with minimum 15 years of follow-up with this kind of stems. But slowly this usage is coming down because of the length and the when it comes to revision, it is very difficult to revise these stems. Removal of these stems is very, very challenging. 45-year-old female, again acetabulum side protrusio with osteoporosis, but the femoral side you can see that is almost like a type B, DOR type B. So here I have used an uncemented stem like the summit stem. Again, cup side we have done a bone grafting and uncemented cup system. So summit again type 3, it is a type 3 double wedge, triple tapered, very good result, but still try to avoid as much as possible. So this is rheumatoid arthritis, 34-year-old female, type B kind of canal, corail stem has been used, and the other side I have used a type 2 accolade stem. So even though the cortex looks thicker in this patient femoral canal, but if you look at the proximal metaphyseal region, due to inflammatory condition, it is very soft and osteoporosis. That is where there was a small periprosthetic fracture which has been wired. So any uncemented system, particularly like a DOR A type, whenever we use an uncemented stem, whether it is a type 1, type 2, type 3, the chance of periprosthetic fracture is high. So we have to be very, very careful. So again, 36-year-old male, this patient, look at the curvature at the femur. This both sides he developed a periprosthetic fracture. So if you look at the literature, DOR type A femurs, if you are using a cementless tapered wedge stem, the chances of periprosthetic fracture is very, very high. So we have to be very careful, try to convert the DOR A into DOR B and then do this. 34-year-old female, rheumatoid. Here it is DOR type B in the femur side, and acetabulum side it is osteoporosis, but she is only 34. So what kind of stem to choose? Here better to choose a reasonably a metaphyseal fixing stem, and also the shortest stem available, reasonably a short stem available, looking at the future revision. She needs anyhow, she will need a future revision. So here I have done a accolade type 2, accolade 2 single wedge stem, that is a type 2 stem, and I have used a uncemented 46 cup and a ceramic head 28. Both sides I have used the same. So in this scenario, this is the most shortest stem available, uncemented system, and she is only 34, she is doing well. So again, one more example. Now this is a bilateral avian post SLE. She is only 30 years. Again, DOR type B canal, and acetabulum wise, it is a avian with secondary arthritis. Here I have used a trident cup 46. So what is the advantage of using a trident cup? 46 cup if we use, we can use a 32 head, and a highly cross-linked poly type 2 single wedge stem like the accolade 2 stem. So this is the best combination, ideal bearing, highly ceramic, highly cross-linked poly with a ceramic head with an uncemented stem and a uncemented cup. So this patient is doing well, 3 years follow-up. So if you look at the corail, which is very commonly used nowadays, if you look at all the meetings, the corail usage is slowly coming down. People are telling DOR type A corail, if you use, the chances of failure is very high. That is the reports are coming out like that. But the corail is the most commonly used system in our country. So if we are using corail, we have to know what exactly the design is and what is the coating and how to do the preparation. If that is the case, the chances of good results are very high. It is a fully HA coated double wedged system. So, and you need to know the system very well. It has got a collared stem. In India, the corail collared stem is a short neck, low offset stem. And again, it has got a high offset stem, and also it has got a dysplasia collarless stem. But we need to know what type of stem, what is the neck shaft angle, and what is the offset it is. The corail, basic corail, the smallest corail starting offset itself is somewhere around 38, 39. So it is almost like even the standard corail is like a high offset stem. So in a short female, stiff hip, it is very challenging to use this stem. So we should try to avoid these kind of stems. So look at this 58-year-old female, stiff hip and very stiff. The movements are very restricted, very painful. And you can see the pelvic obliquity, DOR type A canal. So here if I want to use a corail, it is a real challenge because DOR type A, I have to convert it into DOR type B if I want to use a standard stem. So here what I have done, I have used a corail short neck, which is a short neck corail, low offset, 135-degree angle and an uncemented cup. So with this, I have avoided the standard high offset corail. So in a stiff hip, better to use these kind of stems, low offset stems. We can even use an accolade type of stem, which is also low offset. So 32-year-old male, avian, pinnacle cup and corail system. If it is properly size is selected, if we get a good rigid fixation, stable and rigid fixation, then the chances of failure is very less, whatever stem we might be using. But here the importance here is the offset, leg length and the bone conservation. Whatever stem we are trying to select, we need to know the offset, leg length, bone conservation. Bilateral core decompression done in this patient. Here I have used again an uncemented highly cross-linked poly with corail and ceramic head. DOR type B, corail, and these are all cases done very frequently, routine practice. Avian and rheumatoid is so commonly encountered. 66-year-old female, rheumatoid. Again, I have done with the corail. 6 years follow-up, patient is doing well. So what is the most important thing? The stable rigid fixation, right sizing. So disadvantage of cementless stem, proximal femur fractures, loosening, thigh pain and stress shielding. So right design and the technique of preparation is very important. 45-year-old dysplastic hip. So in this kind of dysplastic hips, the anteversion is more shallow acetabulum, very low offset. So we have to have a modular stem like this with this type 6 stem. SRAM I have used it. So these kind of challenging situation, better to use a SRAM kind of modular system to deal with the altered anatomy. So 50-year-old female dysplastic hip, proximal femur anatomy altered, narrow medullary canal, increased anteversion. So which is the best stem? The other type 2 stems or type 3 stems or corail kind of stems, it is very difficult to adjust the version. So whereas if you try to use a cone Wagner, which is a cylindrical type 5A, which you can rotate this whole stem according to the version which is needed, so that you get your offset and your abductor tension right. If you get your abductor tension right and the right offset, then the longevity is very good. So you reduce the joint reaction force. Then if you reduce the joint reaction force, automatically the implant longevity increases and you get good results. Post valgus osteotomy, you can see the altered anatomy. There is a coxa valga, proximal femur is design shape is altered. So you have to bypass all the screws. So here to get a high and also you need a little higher offset. So I have used a little high offset Wagner stem 190 to bypass all the screws. Again, removal of DHS, distal loading, titanium stem with a uncemented cup. Post septic sequelae, here I am using a doing a subtrochanteric osteotomy. So hence I have used again a modular stem. So but here you need is a small cup. Osteoporotic 73-year-old female, left side THR is needed. I have done a cemented. So don't hesitate to do a cemented total hip. If it is a old age, osteoporotic, DOR type C canal, don't hesitate to do a cemented. Cemented also gives very, very good results if it is properly done. 80-year-old female, definitely you don't want to do a uncemented in this. You want to make the patient walk the next day. 80-year-old female. So DOR type C, very osteoporotic acetabulum. I have done a cemented THR and make the patient walk the next day. DOR type C, 66-year-old. You can see here, I have done a hybrid fixation. That is cemented uncemented cup and a cemented stem. So DOR type C. So most of the time, any DOR type, you can get away with this type 2 and type 3 stems. This is the most important slide. Any DOR type bone, whether A, B, C, you can get away with type 2 and type 3 stems. Only in a complex situation, you will need a type 5 Cohn-Wagner type or a type 6 modular stems. So DOR type C and osteoporotic bone always have a cemented system in your theater as a backup. So summarize in the primary situation, proximal deformity, if it is there or when distal fixation is needed, have a type 5 and a type 6 stems, either a modular stem and a titanium distal loading stem. A new classification is there in 2023. It has been published about this femoral stems. Again, it is almost like a repetition only, but the only thing is they have classified into A, B1, B2, B3. But to put it in a nutshell, you need a type 2 and type 3 stem in your shelf. That is important. So for a good outcome in a primary total hip, the offset and leg length is very, very important. If you get the offset correct, the center of rotation is retained, restored. Once the offset and center of rotation is achieved, then the longevity, stability is achieved. Because of that, bone is conserved. And always remember about the future surgery. Before going into the surgery, know the implant details thoroughly, which will help you to choose the right stem. So take home message, more modern uncemented stem for primary THR with normal femoral anatomy. Cemented stem always as a backup for osteoporotic and pathological bone. A distal loading stem for complex primary or abnormal anatomy or a periprosthetic fracture. Stem selection in revision THR. Quickly, I'll go through the cases. Most important here is area. You have to look for the area of lysis and stress shielding, femoral deformity and cortical deficiency. These are the things you have to look into the x-rays so that it will help you to plan your right implant. So distal bone stock, the most crucial thing in a revision, you have to look out for the distal bone stock. That is where you are going to get your fixation. So based on that, you have to do the templating, whether the implant is loose. If the implant is loose, then you will have a varus remodeling proximally. So you need to take that into account when you are selecting the right stem, whether to do whether to plan a ETO or avoid an ETO. So you plan a ETO so that you avoid cortical perforation, fracture or undersizing. So whenever you take a proper x-ray and see a varus remodeling, better to do an ETO so that you can put in a straight distal loading stem. So how to assess whether if there is an adequate proximal bone to support, if there is a partial support of the bone or possible or not, if the proximal bone cannot support the processes, whether there is an isthmus. So you have to come in order, proximally how much of bone. That is basically how much of femoral bone loss is there, proximal in the metaphyseal and then the diaphyseal, whether the isthmus is there or not. Based on that, you have to select the length of the stem. So what are the causes? Osteolysis, that is, it can cause aseptic loosening, septic loosening, whether the surgery is needed because of fracture or iatrogenic periprosthetic fracture. So again, as I told, for selecting the stem, like we use a classification, the Paprosky classification for femoral bone loss in a revision scenario is an excellent classification. When you try to classify your patient's x-ray, immediately your mind will come to know what kind of implant you need to know and what you have to do and what you should expect or what you will encounter during the surgery. So it is type 1, type 2, 3A, B and 4. These are the 5 classifications. So if you look at this type 1 is what? minimal metaphyseal bone loss, diaphysis is almost intact. Most commonly, you will encounter this in a bipolar process removal and a THR. So one more, this is an example of a type 1 bone loss, a loose implant lying inside, which creates a bone loss in the proximal portion, which is only very, very minimal. You always look out for the previous x-rays and see whether there is implant is sinking inside. So here I have removed that implant. It's a type 1 bone loss. I have used the shortest available length of a distal loading titanium stem. That is the 190. This is left side. So one more example here. Again type 1, aseptic loosening, type 1 bone loss. Distally good isthmus is there. Proximally also metaphyseous bone stock is available, but there is a minimal bone loss. So I have used again a distal loading, but the shortest distal loading stem, titanium stem. So this is the stem I have used 3 years post-op X-ray. So this is again the most common which we encounter in our country, that is post hemiarthroplasty, whether aseptic loosening or septic loosening. If it is a septic loosening, the whole treatment protocol is different. If it is an aseptic loosening, patient will have thigh pain, groin pain. Once that is decided, then you have to remove this, and better to avoid the primary implants here. Here, whenever you see a loose bipolar implant, remove that implant, and better to do a titanium distal loading shortest stem like this, where the results are. So this patient is doing well. Some 5-6 years follow-up. Again, 59-year-old post neck of fracture, the surgeon has done a bipolar for a 59-year-old female. So again, you can see the loosening pedestal sign. So this shows the signs of loosening. You have to remove that uncemented highly porous cup, shortest possible distal loading titanium. This is always my go-to stem, and this is the size which I always prefer to use in these kind of bipolar removals and THR. Hemiarthroplasty, broken stem. If you don't do an ETO, then you remove that ETO. If it is very loose, remove it and then use a distal loading titanium stem. 39-year-old female, DOR type A, which has become aseptic loosening is there. Paprosky type 1 bone loss, again a distal loading stem, titanium stem. 57-year-old female, instability and infection is there. Post debridement, Simmons spacer was put, and again Simmons spacer was removed, and then the adequate fixation. So here, how to choose the right size of the stem? When you get you have to try to increase the size and get a good rigid fixation. The moment you get a good rigid fixation, that should be the length. You should not think that the longer the stem, the better the fixation, or that will create a false fixation. So it will not give a good stability, and the chance of failure is high. So better to have a shorter and thicker stem. One more example, anatomy is altered, lot of screws. Once you remove that, you have to bypass the screw holes, and that is what I have done. So distal loading titanium stem, uncemented cup, and it is only a 190 stem. So non-modular tapered titanium stems are the go-to stems in a revision scenario, particularly in type 1 and type 2. The results are very, very good. So monoblock stems, non-modular stems in type 1 and type 2 bone loss, it is a titanium. Any system, whether a Wagner, Redab or a Recline, it has to be a titanium distal loading stem. So message, shortest possible monoblock tapered stem and a stable and rigid fixation, which gives you a good offset and you can correct the length. Again, two examples of type 2. You can see here what is type 2. Diaphysis is intact, but the metaphysis, there is more bone loss, that is extensive bone loss is there, but remember the diaphysis is intact. Here this is one example, loose proximal portion, the metaphyseal bone loss is there, done an ETO. The moment you do a ETO, you have to plan with a longer stem. You cannot do it with the shortest 190 stem. Here I have used a 225 Wagner distal loading stem and rewired the ETO portion. 3 years follow, patient is doing well. 60 years old female, look at the diaphysis, isthmus is very good. Proximally there is extensive bone loss of this implant. So I have removed that, done an ETO, removed the cement, and I have used a 225 distal loading titanium Wagner stem, and you can see this patient recently came for follow-up, 6 years follow-up. Patient is doing well, and now the patient has got pain in the left side. She came for the left hip pain, and you can see in the right side, you can see the proximal metaphyseal region. Compare the pre-op X-ray 2 years down the lane and now 6 years down the lane. how much of new bone formation is happening in the metaphyseal region. So that is the advantage. When you get the right abductor tension, right fixation, stable fixation, lot of good bone, new bone is formed in the metaphyseal region. So that is the advantage of these titanium distal loading stems. Aseptic loosening, post hemiarthroplasty, again titanium distal loading modular stem, sorry, non-modular monoblock stems in a type 2. Again post sepsis, cement spacer removal and distal loading titanium stem. So message, Paprosky type 2 bone loss, again monoblock tapered fluted titanium stem. But here in this kind of type 2 bone loss, you will require a little longer, 225 or a 240 length. So you need to know, Wagner has got 225, Redab and Reclaim has got 240 length. So you need to know the system, which company has got what length, and you have to plan your ETO accordingly. Type 3A is a little challenging. Diaphysis is also involved, but you will have a very narrow 4 to 5 centimeters, 3 to 4 centimeters only of diaphysis. You have to get your fixation right in that. So particularly these kind of situations, septic loosening, removal of the processes, ETO, such a deep cement penetration, you have to remove that. So once you remove that, you can see so much of bone loss in the metaphyseal region. Still, I have used a distal loading titanium stem. 2 years follow-up, patient is doing well. Periprosthetic fracture, Paprosky type 3A. Periprosthetic fracture, 4 years follow-up with a distal loading titanium stem revision. Patient is doing well. So here, if you see, because of the periprosthetic fracture, the whole metaphysis is open. So you need a good distal fixation, for which you need the little longer stem. 67-year-old female, periprosthetic fracture, again titanium, 3 years follow-up. So type 3B, still more challenging. You can see here, extensive metaphysis loss, diaphysis also less than 4 centimeter. So scratch fit, only small portion of bone is left to get a fixation. So here the challenge was to get the right size. The patient is a very, very tall patient. So I have used a titanium stem, distal loading stem, but still because of the very, very short fixation distally, there was some subsidence in this stem. In this case, but luckily that subsidence stopped at one point, and then patient went on to do well, and it is almost 5 years. By secondary stability, they went on to heal well, and a good outcome after that. So whenever Wagner stems you are using, the chance of subsidence is slightly higher. So the right sizing is very, very important. So if the right sizing is done, the chance of subsidence is very, very low, and particularly this third generation Wagner stems are excellent. So reason for subsidence, aseptic loosening, bicortical contact less than 2 centimeters, particularly higher in type 3B and 4 femoral defect. So you have to right size the right implant, right size you have to select. So 61-year-old male, 25 years post THR, both sides you can see type 3B bone loss. So whenever these kind of situations are there, I always prefer to use type 3B. I like to use a modular distal loading stem. This is the one classical indication where a modular distal loading stems gives you advantage. Why? Because you can get the distal fixation individually, and then proximally you can build it up based on the need for the length and the offset. So that is particularly in type 3B's bone loss situations, modular distal loading stems gives you lot of advantage, particularly in old age patients. So it has the proximal portion comes with various sizes. Accordingly, you can choose the right body to get the right fixation. Again, 85-year-old female, periprosthetic fracture. Again, I have used a modular stem, immediate post-op, and the patient is doing well. Cemented cup was retained. So key point here is good distal fixation and getting your offset and abductor tension. So tapered fluted modular stems becoming more popular, but in complex revision. Need not use it in a routine situation. No need to use in a routine situation. So why apply modularity in revision systems? Because the bone loss is very severe, multiple surgeries, we have to be carefully. You can use a modular system. Again, these kind of complex revisions, you can use a modular titanium distal loading, and this is a 4 years follow. Patient is doing well. So very good long-term results if it is rightly done. But the only key point here is the modular junction has to be covered with bone graft or the patient's ETO bone. It has to be covered nicely to avoid a fracture at the modular junction. That is the key point. It is a desirable in complex femoral revision. So to summarize, advantage of modular stems, yes, limb length and offset can be achieved. Soft tissue balancing is better, less chances of dislocation, less chance of subsidence, but the fractures are stem junction fracture is slightly higher compared to the non-modular one. Does modularity incur specific complication? That is what the stem fracture which I mentioned. So whenever you use a modular stem, try to cover that modular junction area with bone to avoid fracture. So this is what 5 years post modular fixation. So if you look at the literature, both modular and non-modular are equally good results, but use modular only if it is really indicated. So that is the one. Last one is the type 4, which is very, very extensive in all metaphysis and diaphysis, very limited bone stock and osteoporosis. So you have to use a reef system like kind of one with a distal locking, and now with this reef system also they are slowly withdrawing from the market. We need to use some other distal loading with the distal locking titanium stem. So to summarize again, non-modular stem should not be disregarded. It has to be one first go-to stem in any revision. Monoblock stem, type 1, type 2, type 3A. Most of the time you can manage your femoral side revisions with the monoblock stem. Type 3B and type 4, you will require a modular stem. You might get away type 3B also in a monoblock stem, but keeping a modular stem also is a good option. So modular stem is a desirable for complex femoral revisions, but monoblock stem is associated with consistently good results. Thank you. Thank you for the opportunity.
Thank you, Rajkumar. It was a fantastic presentation. I have a couple of questions for you.
Yep.
So one is the monoblock stems are not curved; they're all straight stems.
Yep.
So how do we get around the curvature of the femur, especially when we're doing monoblocks in these complex revisions?
Most of the time when we are doing a 190 stem, that is not a problem at all. So, but when we are the length keeps increasing, that is where majority of the revisions you will be doing an ETO. The moment ETO is done, that curvature doesn't come into a play. So your and first is that point. Second is, that's why I said whenever you see a varus remodeling proximally, better to do an ETO, because the moment you put in a straight stem, the chance of fracture is very, very high. In spite of that, if it is a femoral anatomy is so much, the curvature is so much of bowing, that is why preoperatively take a full length lateral view, and that is the situation you do a modular distal loading stem where the distal portion is curved. Whereas in a Wagner, that Wagner modular stem we don't have. But other modular stems, whatever we have, the distal portion, that 140 to 160 mm length is curved portion. So that is curved and the proximal portion is straight.
So essentially you're accepting a certain amount of malalignment of the ETO portion in order to accept a straight stem.
Yep. So
and
that, most of the time in a type 3B, type 3C, the nature itself has done all those things. Bone loss is there. So that curvature doesn't come into play in a big way. So you can get away.
And the next question is between cables and SS wires.
Always SS wires. Even before completing the question, I can say, I can vouch everywhere. I have all my, this years, I have stopped using cables long time back. Maybe 10, 15 years back itself, I have stopped. All the major revisions, SS wires, user friendly, very cheap, good result.
What are the disadvantages of cables?
Cables, it is bulky. You need that tensioner, cable tensioner, and it is expensive. And I've seen a lot of people fiddling around with that wire, that cable passer, not exactly able to tension it. Whereas in an SS wire, even if it cuts while get tensioning, you can redo it, and you have, it's very cheap also. And when it giving good result, and also remember, our bones are very osteoporotic. Females, osteoporotic bones. That cable itself will compress the ETO fragment.
Yeah. And the idea of converting a type 1 dot type A to B in order to accommodate a corail stem in a tight stem, tight proximal femur.
That's a good question. Nowadays, if you see, even with the senior faculty, we are discussing more about this dot type A. So now the current consensus is, if it is a dot type A, better to avoid a corail stem. That is what everybody's consensus is. So avoid a corail type of stem. and you can use a occluded type 2. Type 2 stems are the better preferred ones in a door type A. Even for that, sometimes you might need to ream a little bit to make it little wider. So better. So basically it is the feel of the preparation. Whichever uncemented stem, when you are preparing the stem, when you are feeling that the distal portion is getting fixed before the proximal fixation, that is the time you need to take it out and ream distally little bit and get the metaphyseal fixation first.
So when we ream, we convert essentially the broach is rectangular.
Yep.
And when we ream, we are converting it into a cylindrical canal.
Yep, almost. So you don't need to ream the entire femur, only the portion. So that's what we need to know, the length of the stem. For an occluded type of stem, the length of the stem is not too big. So you don't need to ream the entire canal. You just need to ream the proximal portion of the metaphysio-diaphyseal junction and then open it out and put the stem. So coming to the youngsters, door type A, the teaching was convert it into a door type B. Yes, you can do that, but better to avoid nowadays, better to avoid a corail type of stem, because in door type A, you will tend to put a smaller stem, and trying to put a bigger head in a smaller stem also, the chance of failure is very high. So better to avoid that.
So what are all the options in the market right now?
That's what, type 2 stem. My go-to stem is type 2 stem.
But I think Synergy is now being withdrawn from the market.
Synergy is actually a good stem, but it is they are trying to, every company is trying to bring out this occluded type 2 stems. So the Actis is getting popular, Insignia is getting popular, occluded 2 I routinely use, good results. Smith & Nephew is coming out with a stem, that kind of stem. So proximally coated short stem with a more like you should have the right amount of offset. So a low offset and a high offset kind of stem should be suffice.
And is J&J also modifying the Corée to help out in a?
No, that's why they brought out to this low neck, low offset collared stem. So now again the trend everywhere is about the collared stem. That itself is an entire one session we can discuss, whether collared or collarless. Not to confuse youngsters, don't worry too much whether to use collared or collarless. You use they can use whatever they are good at. Even a collarless, very good collarless, correctly sized and a rigid stable fixation collarless stems will give good results. So no need to worry too much about that. Get a good uncemented type 2 kind of stem and use it in majority of the situations. If they get good results with corail, they can continue using corail. Corail is not a bad stem. It is in fact one of the most successful stems in the market. So it is the right kind of anatomy, you have to select the right stem. But if you are using a direct anterior approach, better to use this Actis or the Insignia kind of stems. The anatomy of that stem itself is for that approach.
Actis is from which
manufacturer? Actis is from J&J and Insignia from Stryker.
So, Pachare sir, you have any questions, sir?
Yes. Thank you, Rajkumar. It was wonderful to see all the difficult examples and showing the important is the follow-up, which we have shown 5 years, 3 years. That itself indicates that unless you show the follow-up, we will not know what is happening to these patients. 2-3 things regarding cable you were asking. Yes, cable we also stopped long back. Reason is the fretting corrosions which is very high.
Yes.
Where if the stainless steel wire breaks, it doesn't matter. But if the cable breaks, it starts a lot of reactions.
Correct, sir.
So that is another problem of the cables. The cost is different, that we are not worried about academically. Second is what you said. Do you use image when you are doing Wagner stem to know the distal fixation so that you don't get a subsidence? Do you use it regularly?
No, sir, routinely I don't use CM, but in a complex revisions, I don't hesitate to use a CM. That is my philosophy. So it all depends upon the experience, and also the fixation wise distally, the moment what I tell my fellows is, The moment your stem is not going inside, there is some resistance, stop. Don't proceed. Take the C-arm. Check whether you have pierced the cortex or it is hitting somewhere. Check the C-arm. Don't hesitate to use a C-arm in a revision scenario. That is one. But the whether we are selected the right stem size, again you can no problem in checking the C-arm whether the canal is filled with this thing. But remember, there will be a slight difference between the trial and the original processes. So that we have to keep it under consideration, because sometimes what happens is, I've seen surgeons trial, they check C-arm, they think, oh, it's not the right size. They go for the bigger size. That time they get stuck in between when they go for the bigger size, because the sizing is little bigger.
Because Vijay, one of the lecture, he recommending for youngsters, this is for youngsters, to see that you have got the isthmus at least 5-6 centimeter fitting, so that it can show in AP and lateral both image for the youngsters.
Yes, sir. So no harm, no harm. And definitely, yes.
I agree with you. 190 is no difficulty, but anything above 190,
we have to be careful.
Big problem. The second, you are talking about the canal A type.
Yes, sir.
There is a new prosthesis that is brought by our own unit that is known as a consensus. It has got a RDP. It is called reduced distal profile.
Oh, very good. I heard about that. I have not used, sir.
Yeah. So it will take this little difficult, whatever you have described regarding canal A type.
Very good.
Another important thing, Rajgopal, between scientifically.
Yes, sir.
The Coral has been there for more than 30 years in the market.
40 years now, sir.
Yeah, 40 years. Sorry. So if you look at the literature reporting, they have 98%. So there must be so many type A canal.
100%. Sir, in fact, I myself have done so many corals in type A canal.
Yeah. So I don't know how we had to take this to convert, to ask the surgeon to convert from A to B.
So this is a very recent phenomena that we are talking about.
Yes.
Not like, especially for almost half a century
later. That is why not to confuse the young surgeons, particularly in periphery, they don't have all these fancy stems. So what I will suggest is, if they have only coral, don't hesitate to use coral. But only thing is, convert the DOR A into DOR B and do the coral. But the right sizing should be done. They cannot undersize. In the fear of periprosthetic fracture, they should not undersize, or they should not oversize it and create a periprosthetic fracture. That is the most important thing. So the right sizing definitely gives good result. Whether collar is there or not, no problem.
But original coral, no rimming is, there was no rimming at all.
Okay, sir. Okay.
So that is the reason. And just to tell you, I was the person first person to visit the coral.
Oh, okay, sir.
Yeah. I did some work and gave them. Initially, the coral was little on the larger size.
Sir, then so you should collect all your corals, long-term follow-ups, and put it. It will be a real lesson for everybody.
That's okay. Yeah, but secondly, when there is a proximal total bone loss in type 4, we try to use actually nowadays the LPS system. Elderly patients.
Yes,
elderly patients. Not in young patient, elderly patients, so that they can start,
Definitely.
And we don't throw that bone, proximal bone, actually. On LPS, we wrap whatever we have.
Okay.
Wrap the bone.
Okay.
That is important.
The reef, they
especially
are
at the modular junction, what you mentioned.
Correct. And the reef system, J&J has withdrawn, but the Peterborough company has got this MRP Titan with the locking system. This modular stem with locking, that is a little advantage.
I use a lot of bicontact locking, but unfortunately that also is taken out.
Taken out, sir. Yes.
Bicontact locking. Bicontact locking is fantastic because it comes with the right and left, even it is a monoblock.
Sir, I would like to ask you one thing. In your experience, what about the cemented system, in long cemented stem in that type 4? Have you used a long cemented?
No, I don't think.
Okay.
A very elderly patient for a very low demand, that is all right. But I think by and large,
better to avoid. Yes. I don't use that, but I've seen some X-rays. Even international surgeon showing some X-rays with long cement.
That is all right. That's all right. But elderly LPS, if I want to use, I will use the stem cemented. So they can just get about
Yes,
because it's a very wide canal. It's a hose pipe down. So you will not have any fixation with uncemented.
Yes, and also
because there is only very short stay available area for you.
In periphery also, a lot of young surgeons should remember that they should learn the art of cementing. They should not hesitate. DOT type C, inflammatory arthritis, no hesitation in using a hybrid fixation.
I think it is your duty and my duty to actually train our surgeons.
For all the meetings, we should include that because we are concentrating so much on robots and alignments. Cementing is going down very much bad.
Thank you, Rajkumar. Excellent.
Thank you, sir. Thank you. Thank you, Khincha, sir.
Our president, Dr. Khincha, is here. Khincha, sir, would you like to say a few words?
I very actively listened to him and I got a bit confused because I don't do so many hips. But the only question I had, I put it down on paper. He already answered. I was a bit confused and I wanted to know the present scenario and thinking about collared versus collarless stems in revisions or in primary scenario. And when the collar doesn't touch the cut part of the neck, how much do you accept and where do you stop? Is it the distal fix or the collar? And as far as your practice is concerned, do you prefer collar versus collarless?
I will not specifically search for a collared stem. At present, I have excellent result with the collarless stems. So I continue using collarless only. When I'm using that low offset stem like this corals, it comes with a collar. So I use that collar. I always try to seat the collar onto the neck portion. In fact, if it is not sitting, if it is a slight 1 or 2 mm slightly away also, the literature wise also, in my practice also, it doesn't do any harm. What we can do is just pack some bone underneath so that it creates the bridges that gap. But even if there is a gap, we need not worry. That's what literature says. But when it comes to whether to select collarless or collar, definitely at present, there is no definitive evidence to say collared is must. Collarless is also as good as any other system.
So what is the relationship between collar and low offset that you insisted upon, which is a combination that J&J seems to have come up with?
Because the neck is short.
So what is the advantage of that?
In a stiff hip, in a female patient, in a stiff hip, osteoporosis, all this combination, this is the best stem. Because if you are worried about subsidence, there is a collar and the low neck gives you a low offset, the reduction becomes easier. So short females, stiff hip, excellent stem.
So the low offset short neck is for the short size and the offset of the femur, and osteoporosis, you deal with the collar.
Collar. So there's no combination of. It's a very good stem actually.
Okay.
Very good stem.
And you don't worry about impingement there.
No, you don't, because you're not going to impinge because the offset is getting achieved, because already the patient has got a very low offset. So the tension is right. The moment tension is right between the abductors, the impingement. So for that impingement, your cup placement should be correct. You cannot have a compromised cup placement.
Rajkumar, there are no questions from the delegates. There are only 2 things we can conclude.
And can I ask one question, sir?
You go ahead.
Yes, sir. Please go ahead.
JV.
Rajkumar, so when you are worried about the subsidence, when you are worried about the bone quality, the initial fixation, why shouldn't we think of cemented stem?
Yeah. See, definitely. See, there is no. That's why I said, in fact, I don't hesitate to use a hybrid system. That is inflammatory osteoporotic bone, uncemented cup and a cemented stem. All problems solved. Correct. But if at all you are doing sometimes your canal is not that osteoporotic, like not type C, it is a type B, but perioperatively it is soft bone. So that case you can use it. So I don't use a collared stem for osteoporosis mainly. My first choice is for the stiffness because of the low offset. But still you can use a cemented, but sometimes young patients, 35, 40, you deal with. So sometimes you tend to do uncemented. That's why. Otherwise, no harm in using a cemented. That's
again that long cemented stem we were discussing. Paprosky type 4, you said, is a wide canal where you don't have a fixation. I think that is the ideal case to have a long cemented stem.
I've seen that. That's why I asked sir his
Paprosky
experience.
4, osteoporotic, especially rheumatoids, wide canal where you don't have fixation anywhere. Having a short cemented fixation proximally, very high chance of having a periprosthetic fracture down. So to prevent that, especially these rheumatoid and osteoporotic wide canal, a long cemented stem, hopefully not having any periprosthetic fracture. And making the patient early weight bearing.
Mobilization becomes
easier.
Oh, good.
That is one of the indicators.
No, that is the reason I asked sir's experience. In his experience, I wanted to know.
No, even we have used in quite a few patients, only severely osteoporotic, wide medullary canal, Paprosky type 4, when you don't have a fixation, doing an uncemented one, then take a long cemented stem. Especially even in hemiorthoplasties, when you're using a severe osteoporotic wide canal, I use a long cemented stem, cemented, avoid any periprosthetic fracture. That's how.
Previously, J&J was having the C stem, long cemented C stem.
Even though it's available.
Oh, it's available? Okay.
1 or 2 stems they are having, that's available.
Okay.
No, JV, you need a tube intact. You can do it.
Correct.
You need a tube intact.
Yes.
If the tube is not intact, you can't do a cemented.
Correct.
That's why I was telling Rajkumar, when it is a grade 4 type and very elderly patient, sometimes I go for LPS.
Yeah.
Putting a cemented stem down.
That's also a good option, sir. That is actually a good option.
Your point is absolutely fine. Your entire medullary canal and the tube should be intact to do a cemented.
Then only it will work.
Yes.
We have done the past. In 1980s, we had no choice. We had done many of them.
Yes.
Chanley also had a long stem, long cemented stem in the market.
Yes, Chanley is there. C stem, long stem was there.
Yes.
Stryker had a long stem.
Exeter long stems are there.
Yes.
Yeah, excellent.
Yes. Now a couple of Indian companies have come out with the long cemented stems.
Oh, okay.
We are using those ones in elderly patient, severe osteoporotic, fracture neck or peritrochanteric fractures. In those cases, we think of using
peritrochanteric fracture. It is very good for the elderly patients.
Yes, sir.
We have taken on 14 minutes of JV's time.
No, so, but it was a very good discussion.
I think we should start.
But it was a good discussion.
JV, go ahead. Let JV go ahead now.
So we should thank Dr. Rajkumar for a fantastic lecture.
Yes.
From a prolific hip surgeon, we go to a prolific knee surgeon as well now. Dr. JV is from Bengaluru. He's a very leading orthoplastic surgeon in Bengaluru. And he's been kind enough to give this lecture on tips and tricks in the management of stiff knees. So, JV, can you have your time, please?
Yeah, just 1 minute. Okay, Zoom. Give me 1 minute, I'm just opening it. Okay, I'm trying to share my presentation. I got it. Yeah. I've shared it. Did you get that? Did you get that?
See your screen. Yeah,
yes,
we got it. We got it. Yes.
Okay. Today is actually a very interesting topic, sir. Dr. Dipak and Pachori sir has given. It's a TKR in a stiff knee. So I'm sure most of us are encountering stiff knees, and I'll be talking about the stiff knees here. So any knee which has a range of movement less than 50 degrees, we label them as a stiff knee. These stiff knees usually causes a functional disability for the patient. If when you see them, limb and activities of daily living is affected. Stiffness can be in extension or in flexion. So flexion deformity, we know flexion deformity is the one where the knee is in flexion. Further extension is not possible, but further flexion is possible. That is what we call as a flexion deformity. Flexion stiffness is what the patient is not able to have flexion. That is called flexion stiffness. That's the difference between the flexion deformity and flexion stiffness. So that is a basic difference. And for a daily requirement, for a walking, any patient requires 70 to 80 degrees of range of movement. When the range of movement is less than 50 degrees, where we define it as a stiff knee, patient definitely has a difficulty in walking. And for climbing stairs, we need between 80 to 90 degrees for a normal climbing stairs. For a squatting, we need 130 degrees of bending. For a sitting on chair and getting up and moving, we need 80 to 90 degrees. So whenever the patient is having a range of movement less than 50 degrees, all these movements like walking, climbing stairs, squatting, and sitting is definitely affected. So the stiff knee, when we go for a knee surgery in a primary knee with a stiff knee, what we call a stiff knee, there are two main broad categories causing a stiff knee. One, extra-articular stiffness, and second one is intra-articular stiffness. You need to be very clear what are you handling these. When a patient comes to your OPD with a stiff knee, you need to assess the patient before you promise the patient that after a TKR you are going to have a full range of movement. That will be a foolishness and a disaster for you unless you understand whether the stiffness is because of the extra-articular stiffness or the intra-articular stiffness. So basically, if you see the etiology, extra-articular stiffness is mostly because of the post-trauma. Fractures in and around the knee treated either with fixation or a conservative treatment. These are the patients having extra-articular stiffness. Sometimes you have extra-articular stiffness in inflammatory and infective joint disease where your joint is okay, but your quadriceps contracture is there and the adhesions around the outside the joint causes the stiffness. Prolonged immobilization is one of the reasons to have extra-articular stiffness. Remember, it is extra-articular stiffness, and in rare situation, a scarred skin. It can be a bone contracture, post-trauma, multiple scars. These scars prevent the range of movement and causes a stiff knee. And lastly, a post-operative situation, especially we encounter a fracture around the knee joint, especially supracondylar fracture or a proximal tibia fracture, with an open reduction internal fixation done, or somebody has undone a total knee replacement, patient has developed an adhesion because of lack of rehabilitation and physiotherapy. Yes, these are patients with extra-articular stiffness. Malunited fractures and osteotomies done around the knee joint again will cause the stiffness, extra-articular cause for this stiff knee. So basically in extra-articular stiffness, we do have quadriceps adhesion, quadriceps contraction or the muscle retraction. That is very, very important to assess whether the stiff knee is because of the contracted quadriceps muscle or it is because of the intra-articular pathology, and rarely a ligament adhesion. So if you go to the other side, intra-articular stiffness is fibrous scar tissue between the articular surface causing it stiff knee. Especially in a rheumatoid patient, all of us would have operated a rheumatoid patient with a stiff knee. Definitely, there's a lot of fibrous tissue between the articular surface that causes a stiffness. Sometimes soft tissue contraction. And in a post-trauma situation, malunion or osteophytes, interlocking osteophytes within the joints or tenting the ligament causes stiffness in the knee. These are the intra-articular causes. Intra-articular causes can be in osteoarthritis, it can be in rheumatoid arthritis, or a post-trauma. In extra-articular cause, usually it is a post-trauma situation or some kind of surgery around the knee joint or immobilization causing a extra-articular stiffness. If you see a special situation like this, previously surgery done, in these cases the scar is okay, very supple, where you get a good range of movement, the scar is not an issue. But when we have a patient like this, post-trauma situation, multiple scars are there or a huge wound was there which is done with a skin grafting or a plastic surgery procedure. Yes, this is the root cause for the stiffness. It's not the joint, it is the skin, and the scar is the root cause for the stiffness. And here we need to have a special surgical approach, and if required, we need to take the help of the plastic surgeon to get your scar supple, or else you will not get your complete range of movement. And this is another scar which is causing a stiffness. Again, you need to tailor the incision. It is not a midline incision for all these special situation. You need to tailor the skin incision with the help of plastic surgeon. And these scars will definitely reduce your range of movement post-surgically. So you need to plan all your incision with the help of a plastic surgeon. And if you see this patient, a patient with a rheumatoid arthritis, with a burn scar on the popliteal fossa, patient is not having complete extension because there's a huge scar behind the knee. And here we had to use the help of a plastic surgeon to excise the scar, get the scar removed, and get it solved. And then we had to do a knee replacement. This is a patient with rheumatoid arthritis, bedridden patient. And once the scar is removed, patient got a complete range of movement. This is what the patient had post-surgical. After the plastic surgery, once we addressed the scar, she got a complete extension and fairly good range of flexion here. So scar management definitely is one of the contributing factor for the stiffness of the knee, and definitely with the help of a plastic surgeon, you need to look into it, or else you will land up, you will do a knee surgery, but the range of movement, you may not get it. Then the surgical approach for an extra-articular stiff knee is a good surgical approach is must for a stiff or an ankylosed knee. If you don't have a good surgical approach, then you fail to have a good balanced knee. Component malpositioning is very common, and if your approach is not good, then you are very high chance that when you're trying to retract, you're going to rupture your extensor mechanism either proximally, or a tibial tubercle avulsion will happen and damage to your collateral ligament. The surgical approach is very, very important. We know multiple approaches are there. We all know this classical medial parapatellar approach, which we do day in and out. And that is the approach most commonly used in a stiff knee as well. But the approaches like subvastus approach, midvastus approach, lateral approach, yes, lateral approach is very much indicated in a valgus stiff knee, where the knee is stiff and patella is lying laterally. Definitely, that's not a case for a medial parapatellar approach. Yes, we need to do a lateral parapatellar approach.
Ladies and gentlemen, welcome to the approach. You're free to use your mobile phones now. Thank you.
Yeah. So lateral parapatellar approach. Then we have certain trivector approach. Lastly, quadriceps nip. Yes, in a very stiff knee, quadriceps nip is an excellent technique to expose the knee. Remember, quadriceps nip is only an approach for the knee surgery, and it is not, we are not addressing the extra-articular stiffness. Extra-articular stiffness, that is your extensor mechanism, that is the quadriceps muscle, your patella and your patellar tendon. If it's completely contracted, the extensor mechanism is contracted. If you want to lengthen it, then only option is VY-plasty proximally. If your patella is situated in the right place, you do a VY-plasty proximally, then you get a range of movement in the knee. Or if the patella is abnormally situated, use a tibial tubercle osteotomy. You can proximalize or distalize based on the indication, and then you get a good exposure. So VY-plasty and tibial tubercle osteotomy are very important surgical approaches, which also addresses the extra-articular stiffness. So as I said, extensile exposures, we have a quadriceps nip, is an exposure only. VY-plasty acts as an exposure. Tibial tuberosity acts as an exposure and also addressing the extra-articular stiffness. And in a rare situation, there are two different approaches are called banana peel approach and the femoral peel approach, which I'll explain in a subsequent slides. Exposure in a parapatellar approach, the approaches are very important in extra-articular stiffness. So we all know in a parapatellar approach, single long midline incision, and then medial parapatellar incision. I'll explain about this in the next slide. So when you have multiple scars, make sure there is a 7 centimeter bridge in between your two scars. As far as possible, try to use a previously done scar. And if you're not able to get a good exposure, as I said before, use a plastic surgeon to make the decision for the approach. So dissection, we all know in the midline parapatellar approach, release the adhesion suprapatellarly. Once you've done a skin incision, medial parapatellar arthrotomy, and release the adhesion suprapatellarly, and the plane between the anterior and the distal femur should be made. We need to clear all the gutter, medial side and lateral side gutters. remove all the fibrous tissue. We need to debulk or debride the entire fibrous tissue in the suprapatellar area. And patellar tendon identification is very important, and protect the patellar tendon insertion of the tibial tuberosity with the help of a pin or something when you're doing a tightening. So we all know medial parapatellar approach is the standard approach for the knee replacement. Also, it's a very good approach for a stiff knee. Midline incision, we all know, and then we do a medial parapatellar arthrotomy, starting from the proximally and the quadriceps tendon, leaving 1 or 2 centimeters of your quadriceps tendon, so that when you close it, it's easier. Then in the mid part, 1 or 2 centimeters away from the patella, so that the closure is good. Inferiorly, come down to the medial to the tibial tuberosity. So whenever you're doing a stiff knee, proximally open up as much as possible. In case if you have to extend your incision, or you want to convert into a quadriceps nip or a VY-plasty, we need to expose the quadriceps tendon completely up to the muscle tendon junction, so that you need to take a decision on the operative table. So proximal exposure is very, very important whenever you're approaching a stiff knee with extra articular stiffness. So once you have done, if you're able to avert the patella laterally, yes, that is the best situation you have got. In case if you're not able to move the patella laterally, that is where you need to take a decision whether you're going to do a quadriceps nip or a VY-plasty or a tibial tubercle osteotomy. That is where you take a decision. If the patella is lying at the place where it has to be after the implantation, then I would prefer to do a VY-plasty. If the quadriceps muscle is supple and only thing you're not able to lateralize it, but once you have excised all the scar suprapatellarly and down the pouches on the medial and lateral side, and if you're getting a good, fairly good range of movement, then you can manage with the quadriceps nip only. In case you're not able to get a range of movement only, then you do a VY-plasty, or patella is abnormally in position, like in a very high patella alta or patella baja, then you want to adjust the patella height, then you take a decision that you will go to do a transtubercle osteotomy. As I said, medial parapatellar arthrotomy, even though it's used in primary and revision, especially it is used in a stiff knee. Stiff knee, this is the standard approach. Once you do the medial parapatellar arthrotomy, then you take a call whether you want to do the extensile approach. Subvastus approach, definitely it is not a good approach for a patient with a stiff extraarticular or a stiff intraarticular knee. Subvastus is not a good approach. It is good for a lean primary or a revision TKR where your range of movement is good, where your patella is very supple, when you easily subluxate it laterally. That is the ideal indication for a subvastus approach. Whereas mid-vastus approach is again something similar, a modification of a subvastus approach. But again, in a stiff knee, I don't think this is the ideal approach to be done in a stiff knee, that mid-vastus approach. This is how the mid-vastus approach is done. In between the medial parapatellar and a subvastus approach, is in between the two approaches is a line there. And one approach is described for a stiff knee, that is a trivector arthrotomy, where you want an extensive exposure of your proximal part of your wound. Trivector approach, it is seen, but unfortunately, this post-operatively, the extensor lag is so high, and the wound healing issue is there. That's why trivector approach nobody is planning to do. Nobody does nowadays. It has a lot of issues. Most of it can be managed by VY-plasty. As I said, lateral approach, yes, is fantastic for a fixed valgus deformity with a stiff knee. You do a lateral parapatellar arthrotomy just like a medial parapatellar arthrotomy. You release the IT band distally along the adhesions near the GRD tubercle, lateral arthrotomy and proximal lateral border of the rectus. Most of this time, this acts as a lateral release for the patella, pushes the patella medially. And in case if you want to do a reverse VY-plasty, you can convert the lateral approach to a reverse VY-plasty. It's a fantastic approach, but unless you are trained in this approach, you should not go into that area, because lateral parapatellar approach requires little orientation. And if you have done a couple of cases, yes, but as a first time, don't do it. Take a help of a seniors to do that. This is a lateral parapatellar arthrotomy. Then quadriceps snip is definitely, it enhances your exposure, and it increases the range of, whenever your range of movement is less than 70 degrees of flexion, quadriceps snip works as an exposure. Remember, it is an exposure only. You are not addressing the contracted extensor mechanism and extensor mechanism. So it works as an approach. And quadriceps nip usually done in primary and revision knee when you want a little bit of exposure, and it is very safe. Rehabilitation is much faster. There's no quadriceps, there's no extensor lag after the surgery. Quadriceps nip is fantastic approach in a difficult cases, but in an extra articular stiffness, when you want to achieve a range of movement and you want to lengthen the muscle, definitely you should not think of quadriceps nip. So these additional exposures, as I mentioned before, VY-plasty, and VY-plasty is much better to a quadriceps nip in an extra articular stiffness or a stiff bony healed, bony fused knee. Yes, quadriceps nip is not an ideal case. VY-plasty is an ideal approach. So this is how VY-plasty is done. Medial parapatellar orthotomy. On the table, you decide if you're not able to mobilize the patella laterally, and the extensors are so much contracted, is not allowing to have a knee bending, at least 90 degrees of knee flexion is required to do our knee surgery. If it's not allowing, then go for a VY-plasty at the apex of your medial parapatellar orthotomy. Your line of orthotomy comes down and laterally as far as possible till you get your exposure. So VY-plasty, as I said, standard medial parapatellar orthotomy, and then coming down, and described by Coons and Adams in 1943, especially for stiff knee and contracted quadriceps muscle. And definitely it is used in a revision TKA. I can tell you that in my experience, we have done so many VY-plasties. It is a fantastic approach, especially if you get a stiff knee and a revision knee situation. VY-plasty is a fantastic approach. And we have a small modification also. Inferiorly, we try to protect the genicular artery, which supplies the blood supply to the patella. So VY-plasty, whenever you do it in a revision situation, the exposure is so good. Your knee starts coming out to the wound. The distal femur exposure is good. Patella is out of the way. Proximal tibia, seeing the proximal tibia and exposure is so good. So this is a small surgical video which many people don't do. VY-plasty, for them I have put this. It's a revision situation. You can use this in a stiff knee as well. So we have done a midline incision, excising the scar, double knife technique. So once we have excised the scar, you make a big flap medially and laterally, expose your entire quadriceps tendon, patella tendon, and medial and lateral side, nicely make a flap so that you see the entire extensor mechanism. Once you see it, then you perform. That's where you make a nice flap before you do a VY-plasty. You need to see your entire extensor mechanism like that before you make a VY-plasty. So once you have done your flap, you are checking for that. Now, before you decide a VY-plasty, my exposure is there. We only do a medial parapatellar orthotomy. We don't jump and straight away decide about a VY-plasty, but entire mechanism, extensor mechanism is open. We decide on the table, as I said before, whether to do a quadriceps snip in a stiff knee, whether to do a quadriceps snip, whether to do a VY-plasty because of the contracted quadriceps tendon, or if the patella is not lying in the right place, then I will think of doing a transtubercle osteotomy, then my exposure down. First, do a medial parapatellar orthotomy and open up the joint and see the mobility of the tendon. We'll see how much your patella can be lateralized. So once we have done it, so there's the orthotomy done. So, okay, this video, okay. So once it is done, if you can notice here at the apex of your medial orthotomy, you do a one more incision which comes right laterally up to the lateral border of the patella. And once you are stiffening, once you finish your surgery, you stitch your quadricep V into Y at 30-degree flexion. Remember, V into Y at 30-degree flexion, not in full extension. That is the apex I'm closing. We have done a V into Y. So VY-plasty is very important whenever you are handling a stiff knee. You need to learn that, because your stiff knee is used in an extra-articular stiffness is usually because of the contracted muscle. So V is converted into Y. And if you see, we all see all these post-trauma situation, a situation like this, a simple straight medial parapatellar arthrotomy, definitely you cannot do an exposure. There will be a lot of extra-articular adhesions. A VY-plasty, a patella and the quadriceps tendon coming out of the wound is very important to expose your knee joint for the replacement. And some of the revision cases where we have done a VY-plasty, don't worry about the cases, it's a VY-plasty where I'm explaining. And see, a VY-plasty done before the implant removal and antibiotic spacer. And later when we go for the surgery, for the second stage, the stitches are still there. We still do the same VY-plasty. And when you do a VY-plasty, the knee gets completely exposed. Your patella is out of the place. Your patella tendon is out. You are protecting the patella tendon. Your exposure of the distal femur and the proximal femur is so good. You can handle. Here, if you see, the patella is lying laterally, patella here, patella, the quadriceps tendon, patella tendon. Your distal femur exposure is so good, you don't struggle to handle the bone losses during the revision. That's how we have to do a revision where your patella and patella tendon is completely out using a VY-plasty, and we go ahead and do a revision. And remember, VY-plasty, many people give a fear that there is an extensor lag for a patient with a VY-plasty. Yes, they do have a lag to 6 to 12 weeks, and after 6 to 12 weeks, they completely recover. And this patient with a primary knee replacement done with no problems, had an infection of the knee, left knee, rheumatoid patient, 2-stage procedure. If you see VY-plasty done to remove all the adhesion, suprapatellar adhesion during the revision procedure, we went and did the revision, and that's where the patella tendon and the quadriceps are lying laterally. Once we have done it, you can see the functional outcome after a VY-plasty. It is no extensor lag. You can notice right and left knee, there is no extensor lag. There's a good range of movement. One is a primary knee, other one is a revision done. She herself is a physiotherapist. You can see there's no extensor lag. You need not worry about the extensor lag in a VY-plasty. VY-plasty is done for a contracted muscle where you are lengthening it. Definitely, it can be a good approach. This is one more classical example of a patient with a bilateral TKR done, right side got infected, 2-stage procedure, totally stiff, extra-articular stiffness, VY-plasty done, and later reconstruction done, and that is how that razor reconstruction done. If you see here, the exposure of the knee is so good, you can handle most of the problems intra-articularly, and once it is done, you can close your knee, the VY-plasty comfortably. Another patient with 2-stage, all these 2-stage revision, when we come inside, they do have severe extra-articular stiffness. VY-plasty is one of the procedure like extra-articular stiffness to do a revision. And see this patient, right side revision done. First 3 months, yes, she has a 10 to 20 degrees of extensor lag. And the same patient, after 14 years, I'm showing you the left knee is a primary knee done. And the right knee is a revision. You cannot make any difference between a VY-plasty causing an extensor lag. See that? So VY-plasty is an excellent tool to address the extra-articular stiffness. See, that's the exposure you get. So another patient VY-plasty, just to show you that you will never have an extensor lag. It's only the fear. After a few months, see this patient has no extensor lag, VY-plasty. Okay, so in case if you don't want to do a VY-plasty, or there's a patella which is lying abnormally in high position or low, patella alta and patella baja, we think of doing a TTO, transtubercle osteotomy. Fantastic approach. It helps as an approach also, an extensile approach, and also addressing the contracted extensor mechanism. So described by Whiteside and Hohal long back. So we need to have a long osteotomy, minimum of 8 to 10 centimeters. Some people go up to 12 to 13 centimeters of osteotomy, so that you need to adjust the height of the position of the patella, and also if it's a longer osteotomy, the healing is much better. Definitely, it's one of the fantastic approach, and it can address, as I said, in severe contracture or in patella baha when you want to adjust your patella positioning. This is a fantastic approach. The only complication is little bit of extensor lag is there, and sometimes if you have done an extensive dissection, avascular necrosis of the patella and delayed rehabilitation because of the fixation. So these are the extensile approaches which you need to know whenever you are addressing or trying to handle an extra-articular stiff knee. And we'll come to the total knee replacement, extra-articular stiffness, and later we'll talk about intra-articular stiffness. So problems, post-traumatic cases, definitely I showed in all these cases, exposure because of your previous surgery, previous scars, and extensor mechanism issues, that is a contracted issues. Hardware, in case if some previous surgery has been done, an osteotomy has done, or a fixation for a fracture, a plate or the implants inside, hardware issue is there. Malunion, non-union in the metaphysis again is a challenge, and definitely a range of movement. Because of these issues, the range of movement because of the adhesion and other issues, it is reduced. So whenever you have a malunited fracture with a stiff knee like this, you need to address both the problems. You need to address the stiffness, you need to get your length, you need to correct your extra-articular deformity as well. In this case, we did a simple medial parapatellar approach and extensile medial parapatellar approach. We didn't do any VY-plasty. We removed all the adhesions around the fracture site where the fracture had healed, malunited, release all the adhesions, and we did a retrograde nailing, did the corrective osteotomy, and went ahead and did the total knee replacement. Definitely we addressed the deformity, we addressed the stiffness, extra-articular stiffness, and we got a good knee replacement and a good range of movement. Or we get a patient like this, severely malunited, supracondylar fracture, not treated, and definitely you will have a lot of patients with the treated patients. But here it was not treated, severe adhesions, quadriceps adhesion, because it was treated by immobilization, and we need to address that total knee replacement also. Similar principle, expose the knee with a medial parapatellar approach, dissect your entire quadriceps adhesion around your femur, clear your gutters, remove all your scar tissues, then do a corrective osteotomy. You want to put a plate, you want to put an intramedullary nail device, it's up to you, and then go ahead and do a knee replacement. This is how we do in an extra-articular deformed knee. So pre-operative evaluation, you need to evaluate whenever you have extra-articular stiffness, the range of movement. Is the patient is having a neurovascular issues, scar, hardwares, long leg X-ray to check your alignment, CT for your rotations, and plan your correction of your osteotomies. Okay. So surgical challenges, difficult exposure in extra-articular stiffness, poor soft tissue envelope definitely will be there, and altered landmarks. So surgical planning, 3D planning of your joint is essential apart from your exposure. Intra-articular correction of deformities can be done if it's less than 10 degrees, extra-articular if it is beyond 20 degrees. Definitely when you're doing a stiff knee with extra-articular problems, if there is an implant there, we don't want to touch, you release the adhesion. You can think of a technology, navigation or robotics nowadays to get your implant positioning right. So surgical technique, standard medial parapatellar approach in most of the cases. Sometimes only we require an extensile approach, soft tissue release sequentially, and correction of your adhesions, gradual bone cuts, and then if you have to do corrective osteotomy, do a corrective osteotomy and proceed with the total knee replacement. As far as implants are concerned, even in VY-plasty or transtubercle osteotomy, we can go ahead with a simple implants like a PS implants, or based on the need, based on the bone loss, based on the ligament status, you decide whether you want to do a constraint or a knee prosthesis. Yes, post-operative management, Early mobilization physiotherapy, we all want to do, but if you have done a VY-plasty or transtubercle osteotomy, definitely for 6 weeks, you need a support, you need a long knee brace. Don't allow a complete range of movement. After 6 weeks, once you think the VY-plasty has healed or a transtubercle osteotomy has healed, then put the patient into range of movement. Definitely, you will not have re-adhesions. Well, because you have removed all the scar inside, they will not have a re-adhesion. They'll usually get back the good range of movement. Definitely with this extensile approach, we have seen 80 to 90% have a good to excellent results with a good surgical approach. Yes, complications is like any other complication. We'd have a extensor lag, which is temporary. You can have, because it's an extensive approaches in a stiff knee, you can have infection. Sometimes patients do go back to residual stiffness, re-stiffness of the knee because of the pathology. So if you have done a surgery on extra-articular stiffness with quadriceps nip, you can do the surgery and you can close the knee, but definitely this patient will go for re-stiffness. You need to address the stiffness on table, either VY-plasty or transtubercle osteotomy. See, and now we come to a intra-articular pathology. We all know there can be an intra-articular stiff knee. Total knee replacement orthoplasty in rheumatoid arthritis is a classical example of an intra-articular fibrous adhesion. Intra-articular fibrous adhesion, remember it's not a bony adhesion. We all see patients like this.
No, not required.
See, this patient is a stiff knee, and everybody see that it's a rheumatoid patient, even though X-ray says some amount of gap between your bones, but when we go inside, there's huge fibrous tissue there in a rheumatoid patient. So we need to exercise the remove all the adhesions, intra-articular adhesions, and then go ahead and do the knee surgery. And whenever you have an intra-articular pathology, when you do a knee replacement, definitely you can promise that patient is going to get, if you see her now, you saw her gait, you can see her knee, it is so stiff. She cannot bend a knee when she's sitting. That is what I want to say. In rheumatoid arthritis, you have intra-articular fibrous adhesion. After you do a knee surgery, they would get back the full movement. The pathology is intra-articular. It is not extra-articular. Pathology is intra-articular. If you see this patient with a stiff knee.
Female patient suffering from severe rheumatoid.
So intra-articular stiffness because of rheumatoid arthritis, there's a stiff knee, but by doing a resurfacing or the replacement, definitely these patients get back the full range of movement. If you see her, she's getting a good flexion at the knee, her gait improves, and she does not have any other issues. So stiff knee because of a rheumatoid arthritis, you can promise a patient a complete knee bending. That is very important. Whenever a patient comes to your OPD, if they ask what is the guarantee of the range of movement in a rheumatoid patient with a fibrous adhesion, you will get a good range of movement. You will get a good gait correction and pain relief. These are rheumatoid patients. Another patient with a rheumatoid patient, if you see this, almost fused knee, but almost fused knee fused in a flex position. We all get these patients, rheumatoid flex knees like this. It's a completely stiff knee because of the intra-articular pathology, not extra-articular pathology. Here, after doing a resurfacing or the replacement, definitely these patients do a good range of movement. This is the initial post-operative period. And once we start with the rehabilitation, this patient gets up and starts moving. And that's the correction of the flexion deformity. And that's the range of movement. A stiff knee converted into a mobile knee in a rheumatoid intra-articular fibrous adhesion. Definitely you can promise a patient that it is going to be a very good result in these patients. And that patient gets their gait correction and she is able to walk because she had a stiff flex knee. And once we have done the surgery, she is back into normal life. You can see this. And this is again a rheumatoid stiff knee inflection. I'm sure everybody in your practice would have seen these kind of rheumatoids. And this is before surgery. And if you see your X-ray, that is a severe arthritis, even though joint space is there. And then once you do a replacement, you can get a good range of movement. And that's a gait correction, deformity correction. That's the range of movement these patients get. So intra-articular pathology like rheumatoids with a stiff knee, definitely you can promise that you're going to give her 100%. So lastly, we come to a total knee replacement in an osteoarthritic stiff knee. Yes, these patients, osteoarthritis also can have a stiff knee, but in osteoarthritis, the stiffness is not because of the fibrous adhesion. It is because of the interlocking of your osteophytes. Interlocking of the osteophytes or osteophyte impinging onto your collateral ligaments. That is the root cause for the stiffness. And if you notice this, so she's having a good range of movement, but stiffness is there. After doing a replacement, and patient with an intra-articular stiffness because of the osteoarthritis, again like a rheumatoid patient, they will get a full range of movement. These are not like extra-articular pathology where they can have a re-stiffness. Once a resurfacing done, where your pathology was there, once a replacement is done, they will get definitely a full range of movement. That's how you get your range of movement. Definitely, you can promise your patient the range of movement. So lastly, we'll come to an ankylosed knee. Ankylosed knee can be ankylosed in flexion and can be ankylosed in extension. And doing these patients stiff knee is a nightmare. Unless somebody has done these surgeries, younger surgeons should not venture into a bony ankylosed fusion. So bony ankylosis we see in juvenile rheumatoid arthritis, most common juvenile rheumatoid arthritis, ankylosing spondylitis, rarely in rheumatoid arthritis and other inflammatory condition. Most commonly in juvenile and ankylosing spondylitis only we have seen. A patient like this, a bony fused knee with a malunited supracondylar fracture, bilateral hip replacement done, right knee replacement done. This surgeon has done everything, but he didn't venture into doing TKR on a bony fused knee. Remember, bony fused knee is a challenging situation. Once we do a medial parapatellar arthrotomy, identify your femur and patella junction, pass an osteotome and break the patellar adhesions there, and release the entire quadriceps proximally, adhesions proximally. If required, you want to do a VY-plasty, you can do it. But based on your patella mobility, you decide about the VY-plasty or TTO. And then locating your joint line. Usually some tissues of meniscus is always there to identify your joint line. That is where your saw should go and cut create a joint line. Or if you're not sure, pass a K-wire, use a II or use a C-arm image, locate the joint line and then do an osteotomy, and then slowly release the soft tissue right around the femur and flex the knee, and that's how the knee gets exposed. In a completely bony fused knee, be very careful. Release the soft tissue on either side, slowly around the distal femur. Here we have done an extensile approach. VY-plasty we have done, and patella is there. We have done an osteotomy. We have flexed the knee. Once we have done the flexion, at this point, if you are having technology, you have navigation, if you have robotics, is a fantastic instrument to help you to position your distal femur, because we have blindly cut we have blindly created a joint line. At this point, you want to get your rotation right, you want to get your position right. Yes, you can plan some kind of technology help. You want to use a C-arm, you can use a C-arm. Once you have done a distal femur preparation, proximal tibia preparation, and we have used sometimes in these patients, when you're doing a stiff knee, don't hesitate to use a stem extension on either side, because these patients are known to have a periprosthetic fracture during a post-operative period when they're doing a rehabilitation. And when you're doing a bony fused knee, don't hesitate to use a constraint liner, because extensive soft tissue release we have done. We need to use a stem extension and also the constraint liner. So once we have done the procedure, go ahead and close your VY-plasty, and that's how your post-operative image will look. And you have to do this kind of surgeries with the help of a senior surgeon. As a young surgeon, don't try to venture into all this. So why stiff knee is a challenging case? Exposure is one of the most difficult part. Patellar tendon avulsion, very common. To avoid patellar tendon avulsion, you need to put a pin in as you're dissecting, put a pin at the tibial tuberosity so that the patellar tendon does not get avulsed. And getting an optimum ligament balance is again a challenge. Component positioning, again, how much is your femoral flexion, extension, rotation, sizing of the femoral component, and the management of the patella tracking is a challenge. Or when you're doing too much mobilizing the soft tissue, avulsion of the collateral ligament is again a known complication. So always plan stiff knee like planning a revision total knee replacement. It is not like a straightforward primary knee replacement. And before venturing into any kind of stiff knee, always consider sepsis and infection as a cause of stiffness and rule out these conditions before we go for a surgery on a stiff knee. So one technique prescribed is banana peel technique, where you do a medial parapatellar arthrotomy. You do a standard parapatellar arthrotomy, and then you go ahead and do a quadriceps snip in case your patella, your exposure is not adequate. If your exposure is not adequate, you do a quadriceps snip, you have a good exposure. Then after that exposure, you're doing a surgery, you find that patella is not in a right place. You can release the patella, you can release subperiostally the patella tendon as well. So this is called a banana peel technique. And the problem in this is the extensor lag is very high. Extensor lag is very high. Healing problem is there. Wound healing problem, extensor mechanism healing problem is there. So unless it is specifically indicated, don't try to do a banana peel technique. And this is not much advocated unless you are experienced on it. The last one is a femoral peel technique for an extensively stiff knee or an ankylosed knee, which I showed you, the bony ankylosis. That is where the ideal indication of the femoral peel is, where you release the soft tissue subperiostally, the entire distal femur. That includes the collateral ligaments, and posteriorly everything is completely released. That is called a femoral peel technique, where you do a midlines, usually done in a stiff and an ankylosed knee, as I said. You do a medial parapatellar approach, VY-plasty, then you go ahead and start releasing your collateral ligaments medially, laterally, go up to the posterior part till all the soft tissue is released to address your stiffness. Once it is done, then you go for the bony procedure. These are extremely extensile approach. Unless you are trained or seen somebody doing, as a young surgeon, you should not venture into it, because the post-operative complications are very, very high. As far as stiff knee, choice of the implant, based on the stiffness, whether you have if you have an extra articular stiffness, you can still do with the CR knee or a PS implant. Or when you're handling a severely intra-articular stiffness with osteoporosis, what I suggest you is doing a stem extension on both sides with a constraint liner, or sometime a rotating hinge knee implant has to be used. So this, keep in mind whenever you're doing a stiff knee. Choice of implant must be there. Exposure you need to plan. Closure of the wound and rehabilitation. The whole program for the knee is different, not like a primary knee. You need to identify the pathology. You need to plan your implant, need to plan your exposure, need to plan your closure, need to plan your rehabilitation. So with these points, I want to close my talk on TKR on stiff knee. If you have any doubt, you can ask me now.
Thank you, JV. That was a extensive talk on all the ways of tackling quite a difficult issue. I have one question for you.
Yeah.
So you showed some of your videos about the results of the VY plasty, and your range of motion was pretty good, nearly 90 to 100 degrees plus, correct?
Yes.
So could you clarify what was the pre-operative range of motion that those patients had?
Okay. Now I showed it as a revision knee. Okay. But VY plasty, whenever you're doing for extra articular stiffness, in a rheumatoid, in a revision knee also, because it's extra articular stiffness, because the intra-articular you put a cement spacer, that is not a stiff bone. The whole thing is extra articular now. Okay. Now the extensor mechanism is completely contracted. And you have done a medial parapatellar arthrotomy, you've released all the gutters, you released all the scar. In case, if you are not able to get a 90-degree flexion, okay, then only I decide about this extensile approach, not for every patient in revision. But a patient with an extra articular pathology because of the previous surgery, like osteotomies or open reduction internal fixation with the plates, and it is completely contracted, like one of the patients post-trauma I showed, They're almost having 0 to 10 degrees only range of movement, very less range of movement. In these patients, we do an extensile VY-plasty to get at least 70 to 80 degrees of knee flexion so that they have a basic functions.
So basically, the issue is when we do a VY-plasty, we gain about 10 to 20 degrees of length. That's all, isn't it? In the quadriceps musculature. The proximal quadriceps are still contracted because of scar tissue and tightness, especially the rectus and the vastus intermedius.
Yes, exactly. This is what I want to tell. When you are contracted extensor muscle, the quadriceps muscle, that is where we have to do VY-plasty. After doing a knee surgery, they will never get a range of movement. By doing a VY-plasty, you will get 70 to, it's not 10 or 20 degrees, you will get 70 to 80 degrees.
And I have a fair bit of experience in managing doing quadriceps plasties for Thompson's quadriceps plasty for postoperative stiffness of the quadriceps. As well as if you talk to Pradeep, who knows, he will tell you that releasing the rectus, releasing the quadriceps from the femur and releasing the rectus proximally from the hip remarkably improves range of motion in the postoperative period for non-arthroplasty surgeries where you're dealing with quadriceps contracture.
Yes.
So now, what do you think? Why do we as arthroplasty surgeons not think about mixing surgeries like Thompson's quadriceps plasty or even a rectus release along with arthroplasty when we're dealing with these surgeries, when we're dealing with these patients?
So, yeah, what you're telling is correct. If a surgeon is done enough pediatric work, pediatric surgeries, definitely they are all trained in all these things. Doing a surgery, release at the hip and then the knee also. Both the areas they do, they get the length of your extensor mechanism. Here we are trying to do something around the knee because the pathology is around the knee. Previously some surgery, osteotomy or a fracture fixed there. The pathology is there. Only the contraction has happened near around the knee. So we are trying to lengthen around the knee only. That's all. But definitely a patient having a contracted muscle from their childhood, I can think of doing somewhere in the hip release also, proximally release and distally VY-plasty. Yes.
JV,
Sir.
Don't compare children releasing that and these are the post-trauma and other things. So
Yeah,
you can't compare apple to orange.
Yes.
There's a different ballgame. Now, second important thing is, JV, if you are in the mind, you have decided a VY, so why not first to do what is called modified insal snip? Insal snip. So you can extend down.
Yeah. So that is what it is, sir. Every patient we don't do VY-plasty. Every patient is no VY-plasty. VY-plasty is done after you have done your extensive soft tissue release, your extensive medial parapetral arthrotomy, soft tissue release, adhesions and all are released. In spite of doing everything, your patella is not moving, you're not having a good movement only, then you take a decision whether you're doing a VY or a TTO. It is not a straightforward incision, then I'm going to do a VY on this. No. As far as possible, we need to avoid these extensile approaches to get your immediate functions back. Whatever said and done, whether your repair is good or a TTO repair is good, 6 weeks of immobilization is required. We need to avoid this.
Immobilization means you are going to keep in full extension, not allowing them to do a flexion.
What we do is we give them a long knee brace when they're walking because their quadriceps is weak. TTO, if you're fixed, again, we don't allow them to go unguarded. And we give only 20 to 30 degrees of knee range of movement for first 3 to 6 weeks. Then only we try to achieve the full range of movement.
Okay. Rajkumar, you have any?
Nah, actually, it's a very extensive talk and a very good talk. But the only thing is, to be very frank, I don't do VY-plasty at all. I stopped doing it. I stopped doing it. This thing for revision is almost majority of the revisions, 99% of the revisions I manage with snip if there is a lot of stiffness. And I allow all my revision patients day one active knee bending, full knee bending. I don't see any issues with extensor lag. That is my protocol. Even not even 5 degrees of. In fact, knee revision patients, they gain good ROM post revision, second stage revision. Even if I put a static cement spacer, excellently. For a stiff knee, non-revision in a primary situation, I look at it two different ways. One, a post-traumatic situation, particularly when the patella bhaga is there, I will do a TTO. So when I do a TTO, in that way, I can even shift the patella. By invariably, the patella gets shifted a little bit up. So a patella bhaga is an absolute indication for me with the stiffness. I don't even hesitate because you can't do a quadriceps snip and then again do a patellar TTO. Right. So I straight away plan pre-operatively, particularly when the knee is straight. I do a TTO. I make sure there is a lateral sleeve. So that way, when after doing the procedure, suturing, the patella gets shifted little up, patient gets good ROM. I don't do any metal work. I suture it with the ethibond only. And next day, full flexion and extension. Only thing is, they walk with the knee brace for 4 weeks post TTO. And majority of the time, this thing. So it is a two different way of doing it, but that is how my plan is.
Can I add one point?
Yes, JV. Yeah.
Quadriceps snip is an approach for a surgery, for a revision is an approach. VY-plasty and TTO is an extensile approach where we are addressing the contracted extensile muscle. So we are addressing the contracted extensor mechanism. If your patella, again say, if your patella is in good position, I only do VY-plasty if patella is not in good position, as you mentioned. If it is patella baha or patella alta, if I have to adjust that and also get the lengthening of your muscle, then I do a TTO.
Yeah. Down. And the one more thing I accept, but the one more thing you mentioned about the snip. But before doing the snip, in fact, when we do a parapatellar arthrotomy, we have to go both sides extensively, clear the cut and everything. That itself will give us a good this thing. And in these kind of stiffness, we should not try to invert the patella. That is where the problem comes. We only have to put a hormone and lateralize it, not invert it.
Before we do that also, I always put a pin on the tibial tuberosity and then lateralize it. Then only assess your...
Good. I have a good series of cases with only TTO, excellent ROM after, and it heals. I don't use any metal work also. So only ethibond that gives...
No, as you said, if you do a TTO, it is bone-to-bone healing. Once the healing happens, there's no issues.
Yes.
So only thing contraindication for a VY-plasty is when you open up your joint and your quadricep muscle is very thin and you removed all your scar, it is completely thin, it is very friable. That patient, we should not do VY-plasty, straight away do a TTO.
Correct.
Do we have any more? Khincha, sir, do you have any question?
No, I think we are saturated.
All right, sir.
I'll ask him, sir, do you do VY-plasty?
No, I used to do VY-plasty, but I prefer to really extend my parapatellar approach right on the top and use a long periosteal elevator to lift up and see if I can get the mobility back. But in case I have, in the last 2 cases I have done, instead of the VY-plasty, I don't know what this is called, I do a Z-plasty and do a transverse or a vertical slit of the patellar of the quad tendon and lengthen the
sagittal plane. In the sagittal plane.
And lengthen it like we do in the tendo Achilles. And that has given me from 0 to 10 pre-op to 0 to 90 post-op.
Okay. In SICOT Madrid meeting, there was a talk about this. One surgeon presented a video about this one.
I have a major problem of academics, and I have recorded this and I am not presented it, but I have done 2 of this in the recent past, and I have got from 0 to 10 up to 0 to 90 post-op. Very happy, very stable. I'm not sure what this procedure is called, but in the sagittal plane. But for that, the tendon has to be relatively thick, and you got to have a steady hand and should not be out the previous night.
Okay. Pachori sir, can we then close the meeting then?
Yeah, please.
Yes. It's been an. I should. On behalf of the executive board as well as the trust board and all the members of the Indian Society of Hip and Knee Surgeons, it was my privilege to thank Rajkumar and JV for giving two fantastic lectures and sharing their experience, vast experience in the field of arthroplasty. I'm sure whatever has been recorded will be there for posterity to see and learn from because it's online as well. Should thank OrthoTV for carrying this meeting online. And
lastly, Leo, let me thank you, Dr. Pachor and Dr. Khincha.
He's available.
Yeah. No, I've been listening, but I'm traveling, so therefore I've just kept it mute. But I just listened to the talk also. And thank you, as you said, to both the speakers and all of you for conducting and moderating this. The next program will be on 15th of November. And at this time, we take an opportunity on behalf of all of us, wishing everybody a happy Diwali in advance and have a great holidays. Thank you, Rajkumar. Thank you, JV.
Thank you,
Leo,
sir. Thank you very much.
Dr.
Thank you so much. Thank you so much, sir.
Thank you all. I have written to Dipak to take a deserved break, but he can't stay away, man. He won't stay away.
I suspect he's calling from the plane.
Yeah, but this is the first time that we have not had any questions from the delegates or from the attendees. So I'm sure either they have
there is a question for JV there. I think there was in a question box. Somebody asked about that was there.
I answered on behalf of JV.
Okay. All right. Yeah. Okay.
Good night and happy Diwali to all of you.
Thank you. Good night to everybody. Thanks.
Thank you once again, everybody.
Yeah. Bye.
How do you leave this? इधर है
डायरेक्ट से क्लोज
डायरेक्ट क्लोजर हाँ चलिए
Recording stopped.